Alright, this is going to be a discussion on diuretics. So first of all, when understanding diuretics, you need to know that most of them are having their effects on essentially the structures in the glomerulus, after the glomerulus. So this here is the glomerulus, and originally blood comes in through here, and as the blood goes through here, it kind of gets squeezed, and fluid from the blood, hopefully, unless there's a malfunction of some kind, hopefully not cells or anything, but mostly just fluid and some ions are going to kind of come through this little barrier here and get collected in this little area, and then they're going to pass through this way. So mostly it should just be like water and bicarbonate and potassium, calcium, magnesium, sodium, ions like that. If you have problems, other stuff will come through. So it's going to come through. The first place it's going to go through here is going to be the proximal convoluted tubule. And it's here in the proximal convoluted tubule that a drug named acetazolamide takes effect. We'll talk more about acetazolamide in a little bit, but you can see that sodium chloride and bicarbonate, or bicarb, whatever, are being taken out here. Okay, so this is where acetazolamide takes its effect, and typically, these drugs are going to keep ions in here so that the water stays in here, because water likes to follow the ions, and it's going to continue to get pushed through and eventually be excreted out this way and go to the bladder. Okay, so that was the proximal convoluted tubule, and those are the ions involved, and that's the drug involved. Now moving on, we come to the proximal straight tubule, and we leave the cortex, we come out into the outer medulla. And here in the outer medulla is where the drug called mannitol takes effect. We're not really discussing mannitol too much in this particular lecture, cover it later. Now the ions and water are going to come through here, they're going to pass through the thin descending limb. This is where a lot of water is taken out, unless it's bound to mannitol, of course, and it doesn't come out. Goes down through the loop of Henle and comes down here, and this is where loop diuretics take effect. We will be talking about loop diuretics. Particularly, they take effect in the thick ascending limb. So you can see how this was thin, and then now it goes into this thick part here. This is the thick ascending limb. And this is where sodium, potassium, and chloride are normally taken out. And so a drug like a loop diuretic is going to take an effect here in the thick ascending limb, and it's going to work with these ions coming in or out, and it's going to keep more fluid and more ions and whatnot in this area, which is going to keep the water going this way. Now we're coming on to a place where more of these ions are reabsorbed, and this is where typically thiazides take effect. We're not going to be talking about thiazides very much in this lecture, but there are drugs like hydrochlorothiazide and whatnot. So potassium's taken out, calcium. Now we're looking at the distal convoluted tubule. So this is where these thiazides are taking effect. Ions keep traveling through. Some ions are put back in, which is potassium and hydrogen. And now we have the collecting tubule, and this is where potassium-sparing diuretics typically have their effect. In other words, diuretics that don't make you lose too much potassium. So the potassium sparing. Sometimes people can lose too much. And there's where aldosterone takes effect, potassium, hydrogen, and then you've got your antidiuretic hormone antagonists. Okay, that's kind of a basic run over. The ones we're going to be talking about today are going to be acetazolamide and loop diuretics. So kind of these first two pieces, the proximal convoluted tubule and the thick ascending limb. Thick ascending limb and the proximal convoluted tubule. Okay, this is just a big overview of the drugs. We're going to get back to this later, but I just want you to see what players are going to be talking about, kind of see what we're going to be learning about before we learn about them. Again, the ones that are covered mostly in this lecture are going to be the carbonic anhydrase inhibitors like acetazolamide, and we're also going to be talking about loop diuretics in this lecture. And real quick overview, this can be covered several times. We have their method of action of carbonic anhydrase inhibitors, and that is to inhibit the dehydration of H2CO3 and the hydration of CO2 in the proximal convoluted tubule. Their effects is to reduce bicarbonate reabsorption, causing short-term diuresis. In other words, the bicarb doesn't get reabsorbed here. Instead, it stays in here. Diuresis, hyperchloremic metabolic acidosis. Used for glaucoma, acute mountain sickness, edema, etc. Comments is that there are both oral and ophthalmic preparations. We'll talk about that more later. Okay, so that's one of the drugs we're going to be talking about. The other drug we're going to be talking about is the loop diuretics. What do? They inhibit the sodium potassium chloride pump. So if we go back up here, and if you look at all this, you see that there is a sodium potassium chloride pump in the thick ascending limb, and this is where this takes effect. The loop diuretics take effect. So you're going to have, the effects are going to be a marked increase in sodium chloride excretion. In other words, you're going to get rid of a lot of sodium and a lot of chloride, and the water is going to follow that. And you also have moderate potassium wasting as well. Hypokalemic metabolic alkalosis. Whereas if you remember, this was hyperchloremic metabolic acidosis. This is hypokalemic metabolic alkalosis. So difference here, they're both metabolic, okay, so don't pay attention to that. Carbonic anhydrase inhibitors is acidosis, whereas loop diuretics, alkalosis, okay. Maybe remember one of the ions this affects is potassium, and maybe that'll help you remember that how that works. And then, excuse me, maybe that'll help you remember that the K in alkalosis is what happens there. Whereas this one, acidosis, think carbonic anhydrase works with CO2, and we know CO2 is acidic, so maybe that'll help you remember that that's with acidosis. And then understanding this is hyperchloremic, so too much chlorine. And this one down here is hypokalemic, which means not enough potassium. Okay, pulmonary or peripheral edema is what this is useful for. Heart failure, hypertension, acute hypercalcemia, acute hyperkalemia, a lot of things like that. There are both oral and IV preparations. Duration of action depends on the agent, usually 2 to 6 hours. You can have ototoxicity, hypovolemia, hypokalemia, hyperuricemia, hypomagnesemia. I'm not talking about these other ones right now, but just understand there's other ones out there. Thiazide diuretics, potassium-sparing diuretics, osmotic diuretics, and vasopressin antagonists. A lot of different other ones out there too. Okay, so first of all, understanding acetazolamide takes its effect up here, proximal convoluted tubule. Just another illustration of that. Mechanism again, carbonic anhydrase inhibitor causes self-limited sodium bicarbonate diuresis, so you pee it out, and decrease in total body HCO3 stores. What do you use it for? Glaucoma. Remember, it gets rid of some of that fluid back there behind the eye. Also, metabolic alkalosis, altitude sickness, pseudotumor cerebri, urinary alkalinization. Toxicity can be hyperchloremic metabolic acidosis, paresthesias, NH3 toxicity, and sulfa allergy. So a little more discussion about this. Here you see up here in the proximal convoluted tubule is where these things are reabsorbed in the body, and it says that after the filtration by the glomerulus, so after this stuff has been filtered through here, 2/3 of the sodium, but 85% of the sodium bicarbonate, 65% of the potassium, 60% of the water, and essentially all the glucose and amino acids are reabsorbed in proximal convoluted tubule. So pretty much everything, like tons of stuff, is all reabsorbed right here. So what carbonic anhydrase inhibitors do is right here is where they block the reuptake of the sodium bicarbonate, and that's going to have a big effect because it's so early on. I mean, because that's where so much happens there with that. Says, yeah, I won't go over the rest of that. It's pretty straightforward. This is showing kind of a breakdown of how this works. Down here. I don't think that's super high yield, but it does show here a little bit more of specifically what's happening. You can see these ions going out and coming in and whatnot. You can look over that if you want. Just kind of a repeat, but now making it clear that the drugs that take the effect with the eye drops for the carbonic anhydrase inhibitor eye drops is going to be the dorzolamide and the brinzolamide, whereas the oral drug is going to be the acetazolamide, the dichlorophenamide, and the metholamazine, whatever. So maybe what you can do is the ones that I guess they all end in amide, so that's a good way to recognize these carbonic anhydrase inhibitors. But this one's got a dorso and a brinzo, and what I'm seeing is they both have the letter S in them, whereas I'm not really seeing any S's up here. So maybe what you can think is that eye drops. So these work in the eyes. So maybe you could think of someone that looks like this, and if you see this S's, then you think of somebody with like S's for eyes or money signs for eyes or something like that, to know that it works in their eyes. You can pay money to help your eyes out. Glaucoma. Mechanism action inhibits hydrogen secretion of proximal convoluted tubule, inhibits sodium reabsorption. Again, we already talked about a lot of this stuff. Note here, though, is that this stuff only works for like 48 to 72 hours, and then by then your body kind of starts to compensate by producing more bicarbonate. So it only works for a little while, but it can also, in regards to glaucoma, it decreases the secretion of bicarbonate in the blood that serves the aqueous humor. Contraindications are going to be, well, kind of obvious things. If you have severe hepatic necrosis, you wouldn't want to take this stuff. Hyperammonemia, what is it going to do? It's going to further concentrate the fluid, never mind, forget that. Yeah, I guess hyperammonemia is a bad thing. I think the reason why is because, as I was trying to say, is that the blood, your serum now, if it's losing a lot of its fluid, it's going to even more concentrate this ammonium. Asterixis, hepatic encephalopathy. I want to give it to people who are lactating or pregnant. It can cause oligohydramnios. It's kind of like problems in utero with the baby. Adverse effects of oral acetazolamide is going to be drowsiness and paresthesias, acidosis and CNS toxicity, fever, rash, bone marrow suppression, and interstitial nephritis. Toxicities are going to be hyperchloremic metabolic acidosis. You got to remember this one's the one associated with carbonic anhydrase inhibitors. So you think carbonic anhydrase carbon acidic. So remember the acidosis. They're both metabolic, that's easy to remember, but hyperchloremic. So you get too much chlorine. So trying to think of some way to help you memorize this, but too much chlorine, so high chlorine levels. Maybe what you can think is C for chlorine, and C for carbonic anhydrase, and C for carbon with the acidosis. I don't know. I'm trying to think of something that'll work, but remember hyperchloremic, too much chlorine. Also, toxicities can cause kidney stones, phosphaturia, hypercalciuria, and hyperkalemia. Too much calcium, too much potassium. Okay, another little breakdown. Now we're going to be talking about loop diuretics for a moment. Some loop diuretics, furosemide, bumetanide, and torsemide. Mechanism of action of these loop diuretics is going to be to inhibit the co-transport system. I want to go back to the earlier slide though that we had, and a lot of garbage written on here, but essentially just see that these guys are going to take effect. Just remember, we discussed earlier, these guys are going to take their effect right down here with the thick ascending limb. Okay, that's where the loop diuretics take effect. Sodium potassium chloride exchanger. Okay, so it shows it again right here after the thin part. Sulfonamide. So a lot of these have sulfur in them. There's one that doesn't. We'll talk about that a little bit later, but most of them have sulfur in them. They inhibit co-transport system, sodium potassium chloride, a thick ascending limb of loop dependently, abolish hypertension of the medulla, so they make the medulla less hypertense, preventing concentration of the urine, stimulate prostaglandin E release, which has a vasodilatory effect on afferent arteriole. I think A for approaching, E for exit. Afferent, A, approaching, efferent, E, exit. So it's saying here that it vasodilates the afferent, so it makes this one bigger, so more fluid goes into it. More fluid goes into it, it's likely that more fluid is going to come out this way too. And it is inhibited by NSAIDs. So if you take too many NSAIDs, it actually kind of competes with the action of these drugs, and it's going to have less effect. Maybe that's because they're prostaglandin E, not really sure. Increases calcium excretion. Just think loops lose calcium. Clinical use is basically anytime you have lots of edema and stuff, or heart failure, cirrhosis, nephrotic syndrome, pulmonary edema, hypertension, hypercalcemia. Particularly hypercalcemia in this one because this does get rid of calcium. So if somebody is hypercalcemic and they come in, you want to give them a loop diuretic because this is going to make them get rid of calcium. Kind of an illustration here of what's happening. Thick ascending limb. I'm probably not going to go through that right now, but just understand that this symport system, this guy right here, is going to be inhibited or blocked by the loop diuretic, and have that effect. Next, we have the a little bit more of the breakdown of what's happening here. Not going to talk much about this, but there it is. Okay, so loop diuretics, understand they're sulfur derived. Got drugs like furosemide, torsemide, and bumetanide. Note here, torsemide is not eliminated by the kidney, and furosemide lasts 6 hours. So it's called Lasix. So torsemide, yeah, I don't know how you're going to remember that. There also is a non-sulfur derived drug called ethacrynic acid. So ethacrynic acid, if somebody has a sulfur toxicity, you can use this drug. The mechanism of action of loop diuretics is to inhibit the sodium chloride reabsorption by blocking sodium, potassium, this symporter, sodium potassium chloride symporter. The use is going to be volume overload, as we discussed earlier. Yep. Apparently, the way you work with this, if age plus BUN, it's going to equate your daily furosemide required for patients with GFR less than 30 to 40 milliliters per minute. Contraindications, sulfur allergies, unless they're using ethacrynic acid. Don't want to give it to somebody who's lactating or pregnant. Adverse effects includes rash, eosinophilia, interstitial nephritis, dehydration, hyponatremia. Toxicities are going to include hyperkalemic metabolic acidosis. So hypokalemic, low potassium. Metabolics in both of these two, and then acidosis. For some reason earlier I think I had alkalosis, so I think that might actually be a mistake. Let me double check that real quickly. I want to catch mistakes so we don't make them here. Where would I find that? Here it is. So yeah, here that's a mistake then. So here he says metabolic alkalosis. So make a note of that. Hypokalemic metabolic alkalosis. So the K for kalemic, K for alk. And those are associated with loop diuretics, which affects the sodium, potassium, which has a K, chloride channel. Okay? So pay attention to that. Other note, pulmonary edema. If somebody has pulmonary edema, apparently the first thing you want to do is give them oxygen. The second thing you want to do is give them a loop diuretic. Third thing you want to do is give them a nitrate. You want to give this to patients with hypercalcemia, and also know that NSAIDs weaken the drug's effect. Yep, know that. Here's kind of a comparison of this. I mean, it looks to me like mostly just want to find things that are really outstanding. For example, chlorothalidone. Look at that half-life, 40 to 60-hour half-life. So chlorothalidone has a really huge half-life, whereas chlorothiazide has a really short half-life. Now, so here we're talking about thiazide diuretics, so maybe not really pertinent to what we're discussing this particularly, but maybe a good thing to compare. Now, if we're going to compare this to our loop diuretics down here, I guess it goes all the way down. See, that's 2 hours for furosemide, torsemide 3.5, metolazone 14, ethacrynic acid 6 to 8, maybe, I don't know. Trying to think anything else here that is significant. It does say torsemide, it lasts longer than the other ones, most of the other ones anyways, and that it also is hepatically cleared. So torsemide, hepatically cleared and longer acting. No, this one down here, ethacrynic acid, is not a sulfonamide. Looks like hydrochlorothiazide is the cheapest one out there. Yep. So it looks like they might do some combining of some of these other ones. We won't talk about that too much right now, though. Again, this is a review of everything we talked about earlier. I feel like we covered everything pretty well, so I'm actually not going to talk about that right now. I think we're done.